Hello, this is Miss Catlin. I'm going to be recording for our Adult Health 2, Chapter 9 and 10. There isn't really much in Chapter 10, so I just included it in here because I'm just going to hit key points on that chapter. I found this picture. I thought it was really good on helping explain for heat loss, for hypothermia and hyperthermia, how we lose heat and how we get overheated. Just trying to distinguish between the radiation is heat generated from within the body, is given off to the surrounding atmosphere. Evaporation is when you sweat or when your skin or clothing gets wet. The evaporation of that liquid promotes heat loss, and the natural result is a cooling effect. Convection, which is showing over here. Convection is the process of air or water flowing by the skin and carrying away body heat. It's convective heat loss that you try to prevent by staying as still as possible in the water. That prevents hypothermia. Staying still, the boundary layer of the water next to the skin is heated by the body and remains undisturbed. If you move around in the water, you disrupt that boundary layer of warmer water, and that increases heat loss. Conduction is the body conducts heat to whatever the skin is in direct contact with. Conductive heat loss occurs when the skin is subjected to either cold air or water, but is especially critical in water, as your body loses about 25 times heat 25 times faster in water than in air of the same temperature. And not that you need to memorize these. I'm just, covered it in PEDS too. I'm sure you covered it in maternity, OB. And just as we get into heat exhaustion and frostbite things, just to help you have an understanding. This is just another that was a good picture of hypo and hyperthermia. Just some predisposing factors. High temperature and high humidity. So high temperature is actually when the external temperature or the temperature around you is greater than 95 degrees Fahrenheit, and high humidity being greater than 80% humidity. And actually, if you think of some places like Florida or Central America, you might actually hit both of those very easily. It can result in heat exhaustion or heat stroke, and we'll distinguish those in a minute. Exercise and activity, obviously. Age, the older and the younger. Older have poor thermoregulation. They may be on medications that can exacerbate it, or maybe like a diuretic. They are not able to always move and get away from the heat source as easily, just as the newborn or infant has the same problems, except for medications. Let's see. Exposure, pre-existing illnesses such as heart disease. They may be obese, have an infection of fever, fatigue, diabetes. They may already have been dehydrated prior to the heat exposure. There's a chart in your text, chart 991 on page 121. It just talked about heat-related illness prevention. It's just a real good, simple presentation there that you might want to look at. Okay, so heat exhaustion. There's heat exhaustion and there's heat stroke. Some of you may have had an incident in your life of a heat exhaustion. As you can see, the definition and the clinical manifestations and treatment. It can occur in a matter of hours, or it may occur slowly and accumulate over the course of several days. It's a loss of fluid through perspiration. This leads to losing sodium, and the more sodium you lose, the higher the risk to develop a heat stroke. The flu-like symptoms are headache, weakness, nausea, vomiting. They don't necessarily have to have an elevated body temperature to have a heat exhaustion. Now, treatment, stop physical activity, transfer to a cool place, replenish with fluids. Do not give them regular water. If you want to try to give them, you want to replace the sodium loss, so you want to give them rehydration solutions or sports drinks. Do not give them salt tablets. You want to remove as much clothing as you can or constrictive clothing. Give cold packs to the neck, chest, abdomen, groin is what your text says. I added armpits. That's another place you want to do it, because these are the critical areas of your body. They tend to be warmer than the surrounding tissue of your body. The blood flow through major blood vessels are near the skin surface in these areas. So the neck, armpits, groin have a high heat transfer. So if you either put heat there when you're trying to warm them up, put cool there when you're trying to cool them off, it's to give the most rapid response. Heat stroke is a medical emergency. There's two types: exertional, which is a sudden onset, and classic occurs over time. I was surprised to read in the text it's several hundred deaths a year due to heat stroke. And I was not surprised to hear that it's the majority elderly. There's, where is it, page 122 in your text is an evidence-based practice talking about non-exertional heat stroke. It just found it interesting. You may want to read that. I don't know if some of you have lived in other areas. I know working in Florida for years and St. Petersburg, where large elderly population, especially doing home health, we had people with heat exhaustion and even heat stroke that we'd find in their home. Or I'd take care of people in ICU or ER having been found in their home with heat stroke. Clinical manifestations, as I noted, chart 9.2 in your text goes over those. It's just the skin is hot and dry. They may still be sweating. Even the heat exhaustion, heat stroke, they may still actually perspirate. So the heat stroke, skin is hot and dry, and then their temperature is elevated to more than 104 degrees. They're confused, bizarre behavior, may progress to seizures, coma. They are hypotensive, tachycardic tachypnea. So their pressure's low, heart rate is up, compensating, and tachypnea, blowing off that CO2. They go into a multi-system failure. And the treatment, also in your text, on 9.3, goes into it more than we really need to know. It's really just remembering your ABCs: airway, breathing, circulation, high concentration of oxygen, several IV lines, getting normal saline going, Foley catheter because you're closely monitoring their intake and output. You're using cooling techniques, and you want to stop their shivering because you don't want their body to increase the body temperature. So stop shivering. I know in my experience the text mentions benzodiazepines. Valium's one that I've seen used as long as their blood pressure can handle it, but usually you're dumping in fluids and other things same time. And rectal temperature. There are rectal probes. I don't know if anyone's seen them yet, but there are rectal probes that keep a constant temperature regulation. It's usually connected to, if you have a cooling blanket on, it usually has one attached to it. Okay, so now cold-related injuries or hypothermia occurs when the core body temperature is less than 95 degrees. The text listed the three categories for you. And I found it interesting also, the text noted that when the temperature outside is below 82 degrees, that can start to impair the thermoregulation on certain people, such as the very vulnerable elderly, hypothyroid, or someone like that that's more at risk. Next slide, we're going to go over some predisposing factors. Here we go. So the cold environment, such as snow or stuck out in the ice, somebody who's homeless, has to work outdoors for hours, cold water immersion. Again, the elderly, people with chronic illness, people with lack of exercise, certain medications, and a lot of those medical conditions may exacerbate the elderly that's already at risk. Hypothermia risk when they have medical conditions, such as if they're in a trauma, they're in shock, head spinal cord injury, severe burns, or severe infection. People with diabetes that are hypoglycemic, hypothyroid, certain drugs, and if they've been exposed to a poisoning. Malnutrition is another factor. Okay, so hypothermia, assessing what you anticipate finding in the mild. Let's see, I have a chart. Let me find it here, 9-7. Trying to find it in the text. Okay, so that one is on page 131. I kind of skipped. I'm going to come back to the middle of the chapter. I felt like we should go straight from the heat to the cold. Anyway, I just changed the order a little bit. Not that I need you to memorize this. You can kind of figure this out. If you're looking at mild, they will be shivering. Diuresis. It's an interesting thing where the body starts to shunt. And we used to call it high output failure. Before everything gets worse, they start dumping their fluids. Decreasing mental status and decreased muscle coordination. The next slide, we're going to go into a little more moderate to severe. I kind of group these together because it's just having an idea to distinguish. The moderate's going to have muscle weakness, poor coordination. As it progresses to severe, they're going to have a decreased neurological reflexes. The moderate's going to be confused, apathetic. When you get more severe, they may even become comatose. Clotting factors are affected anytime somebody is having a body system shut down. And with severe hypothermia, there's cardiac and respiratory involvement. Okay, so I thought I went to the next slide. Sorry about that. Patient care, rewarming, keeping them in a supine position. Hypotension, positional, postural hypotension is significant, so keep them laying on their back. You want to rewarm them in the core. Don't worry about laying blankets on the extremities. You want the middle of the body. You do not massage the outside extremities. If you warm the extremities first, it causes the extremities to vasodilate, and that cold rushes into the core of the body. And the core, of course, is where your vital organs, your lungs, and your heart are. And you don't want them going into VFib, ventricular fibrillation. It's very difficult if somebody is very hypothermic and you try to shock them out of VFib. It's very unsuccessful until you get the body to start to warm up. So rewarming them if you're outside, getting them into some sort of shelter away from the cold environment, remove their wet clothing, put heating blankets on, warm packs to the core areas, the neck, the armpits, the chest, the groin is where you want to warm. You want to, if they are able to take in any liquids, you want to give them warm liquids. Avoid alcohol, avoid caffeine because it can have a diuretic effect. and alcohol causes dilatation again of the periphery and will bring your core temperature down. There is a saying, it's in your text, I've heard it before, it's one that is worth remembering. No one is dead until they are warm and dead. Like I said, when you try to defibrillate someone that is hypothermic, it's going to be unsuccessful, but there is a chance as you warm their body and shock them again to bring them back. So no one is dead until they are warm and dead. Okay, now local cold injuries, frostbite. Definition of frostbite is the actual body tissue freezes. There's frostbite and frost nip. Nip is when it's just superficial freezing, not actually down into the tissue. It's easily reversible. Frost nip versus frostbite. It usually occurs in the extremities. Symptoms initially is very painful, leading to numbness and getting pallor, loss of color. There are 4 degrees. First degree is when it's very red. Second degree, as you can see in this one picture, some of the larger blisters here. And I think this is progressing into third degree, because third degree is when you see these small, dark, fluid-filled blisters that are starting to form on here. The skin is cool and numb. Second and third degree, there is partial thickness necrosis, and if you get to fourth degree, that is full, no blistering, no edema. It's totally, blood is bloodless, totally absent of blood, and there is a full thickness necrosis of the tissue there. With frostbite, the edema and the blistering occurs within 24 hours of the injury. Main risks for this are inadequate insulation, fatigue, dehydration, poor nutrition are increase the risk factor. More people that are at risk are smokers, because it affects their peripheral circulation. Anybody with poor peripheral circulation, or if they have a previous history of frostbite, all those increase their risk of developing frostbite if they're exposed. Member compartment syndrome, we'll talk about that more later in this semester as we get into musculoskeletal trauma and injury, but you're watching for that compartment syndrome and giving tetanus if the tissue is necrosed, and anticipating if it's necrotic that they are going to have some debridement done. I didn't realize I left that picture in there because I had it on the other page. Anyway. Okay, so now we're going to go into drowning. We just skipped a little bit. I'm going to come back to the high altitude. The drowning starts in your text on page 135. Yes. Of course, prevention. Safe rescue, especially in water. If it's a diving or something unwitnessed, you're being careful with cervical spine. Airway, breathing, circulation, ABCs, always ABCs in here with the cervical spine too. CPR, obviously, if necessary. Gastric decompression, supportive body systems. Drowning is still one of the leading causes of death in the United States. They no longer use the term near drowning. It's just a drowning, period, and just whatever the outcome is. Salt and fresh water, either if they drown in either environment, both of those wash out the surfactant that's in our lungs that help reduce that surface tension, and that's needed to improve the lung alveoli compliance. And you just learned that in OB, talked about surfactant with the infant or the premature infant and the lung difficulty. So the salt and fresh water getting into the lungs can cause the loss of surfactant, and they will develop pulmonary edema. their outcome is really reliant on how long they've been deprived of oxygen and how low their oxygen levels went down. Complications, of course, are adult respiratory distress syndrome, which we'll get into more later in the semester, and, of course, central nervous system impairment. Okay, so snake bites. Snake bites are in your text, page 123. They have an awful lot covering snake bites. I included the one on the bottom, which is the coral snake, which is poisonous. A snake bite can be a medical emergency. You're going to assess for puncture wound, look around the site itself, looking for localized reaction. Try and, if they have killed the snake, brought the snake, have a picture of the snake, something, so you have an idea what kind of snake bit them. Not all are venomous. The systemic effects can be anywhere from 8 to 13 hours on the two that your text refers to as the venomous. The North American pit viper may be up to 8 hours before when they become systemic symptoms. The bite itself is painful and ecchymotic. It's like bruised looking or red or both. Where the coral, the other venomous one in the United States, can be up to 13 hours before it becomes systemic, but it's a neurogenic presentation and its onset is very, very rapid. There is no anti-venom in the United States any longer for the coral snake bite, one that's neurogenic, so treatment is supportive. Often will end up on a ventilator for a while until they recover from this. But there is an anti-venom for the North American pit viper. Unfortunately, when you get it, anti-venom can result in a serum sickness, or it's a hypersensitivity reaction. It develops within 3 to 21 days after the anti-venom is given. It begins with a skin rash and it progresses into a fever, joint pain, sometimes itching. Very, very rare that there's an anaphylaxis. Of course, if the tetanus prophylaxis with any kind of puncture wound, lab work looking for anticoagulation problems after the bite. Okay, so living in Tennessee or Alabama, I think everybody's pretty familiar with brown recluse and the black widow spider. I have an old house on my property that's full of brown recluse spiders, and thankfully have not been bitten that I'm aware of. A lot of times the brown recluse spider bite will get, because they are recluse, they like to hide away. So people are usually bitten when they're reaching in, like in their garage or somewhere, into a box, or when they're sleeping. It results in ulcerative lesion. The brown recluse itself injects a venom that causes cell damage. It's rare that becomes systemic. It can. If it does become systemic, it can lead to renal failure, leukopenia, seizures, hemolytic anemia, and a coma. The initial systemic symptoms are rash, fever, chills. Treatment for any spider bite, any kind suspected, is always put cold compresses. Do not put heat on it, because you do not want to spread that venom. You want to keep it isolated to that one place. You want to elevate it, again preventing spreading. If it's whatever the wound is, you do appropriate wound care. I know I've had lots of people come in clinics talking about they have a spider bite, which is often an abscess of some sort, but not a spider bite. Many people mistake it for a spider bite. But if there's suspicion of a spider bite, you ice it, elevate it. Okay, so the black widow affects the, oops, I see I have a typo here, I apologize, it's neurotransmitters. It is very painful, whereas the brown recluse people often aren't even aware that they were bitten. So the black widow can be very painful, treated with opioids for that pain. There is an anti-venom for the black widow because it does affect the neurological system and the neuromuscular. The anti-venom can be given, will be given when a woman is pregnant because the venom from the black widow can cause contractions of the uterus and make them lose the pregnancy, the child. Even though they recover after the black widow spider bite in a few weeks, it can relapse and present the same symptoms again. Again, applying the ice initially to the site. They have to give, because of the neuromuscular effect, they are given muscle relaxers. They have a tetanus prophylaxis. Blood pressure, because of everything tightening up, they're treated with antihypertensives. It can result in pulmonary edema, uncontrolled hypertension, and even shock. Scorpions. I've not been exposed to anybody that has been bitten by or stung, whichever you want to say it, by a scorpion. I know when I did a medical mission in Guatemala, I did see some scorpions. Thankfully, they were not on me when I saw them. Most species venom effects are typically self-limiting, which I wasn't aware of. I always thought that they were always severe. The one called a bark scorpion is the one that is potentially fatal. Otherwise, the rest usually are not. Any bite by a scorpion may result in some paresthesia, tingling, numbing for the first couple weeks. You're going to monitor vitals, ice to the site to treat the fever, tetanus prophylaxis, wound care, kind of along the same lines here. The text goes into bee and wasp stings. I didn't make an extra slide for that. Just if they're allergic to bees and wasps, they need to have an EpiPen available. That's part of your teaching. They now make these Epi twin packs, so it's good if they have a twin pack, because the problem is if they use one and they get stung again before they have another one if they need it. Because anaphylaxis is a true medical emergency, results in respiratory distress from bronchospasms, laryngeal edema, hypotension, cardiac dysrhythmias, which sounds a lot like a response from a venom, but each is a medical emergency. Okay, lightning strike in your text page 129. It follows the bees and wasps. So we're following along here in your text. Again, prevention, education, teaching people the risk factors, not to be out hiding under something when it's raining out there. There are some places that are higher risk. I know where I lived in Florida was on the part of the lightning capital. There's a line for the lightning capital. Very few people die after a lightning strike, but it can cause permanent disability. Asystole is the most lethal initial effect on the cardiopulmonary system. Treatment is immediate CPR. You are not in danger if somebody is hit by lightning. You are not in danger by coming in contact with them. You will not get shocked or hurt. Again, they usually have a numbness of the low extremities initially, which will resolve after a few hours. If the lightning has resulted in burns, watch for rhabdomyolysis, which is, I think, something we will cover a little further later. That's where you're monitoring their CK. CK is the creatinine kinase that was released from the muscles with muscle injury, and those breakdown of the muscle and proteins messes up the kidneys, leads to renal failure. Also, here we go again with the tetanus prophylaxis after a lightning strike, or if they have burns due to it. We are actually almost high altitude illness or disease, which comes right after, let's see, your frostbite, page 133 on your text. I just went ahead and listed the 3 types here: mountain sickness, high altitude cerebral edema, high altitude pulmonary edema. It's pretty self-explanatory here. You have to let your body adjust to it. I know when years ago, another medical mission was out in Bolivia, and we went hours up into the Andes Mountains. Didn't think about it because we were on a bus, and when we got off, after like 4 hours up, the altitude was so high. We were all from Florida where there's no altitude. When we got off the bus, the locals told us not to do anything, just to sit and wait for a while. And a couple of us were stubborn and tried to pick up our bags and go up, and got dizzy, chest pain immediately. And we had to stop and get our body to adjust before we could move. Okay, so that wasn't so bad. Now just chapter 10 goes into emergency and disaster preparedness. I just give one slide going over some few of the facts to cover, because I think you're going to cover more of this in community health. And there's really not much as you get out and you're working, depending on where you're working as a registered nurse, you will learn more about this specific to where you're working. A disaster is anything that is beyond the resources of wherever this occurs. So an internal disaster occurs within a facility or on a campus. An external disaster occurs outside in the community. NBC stands for nuclear, biological, and chemical threats. All emergency department personnel are now required by law, by regulation, to have NBC training. Everyone in hospitals gets hazmat training, more so depending on where you're working and what the expectations of that facility. If you're working in a level 1, level 2 trauma centers, they often have more teams for that you are actually assigned and specifically trained. Anybody with previous military experience has probably been trained in these things. And there is, if you decide down the line that you want to work in public health, registered nurses do work in public health, or in the health departments do in public health, and they may have specific training for casualties and NBC, hazmat, and all that. Mass casualty. There's a chart in chapter 10, 10.1. Let me find it here. It's just doing the comparison, because we chapter 8 went over triaging in the emergency room. We're a little different when it's a mass casualty. It is done the way it is done in the military, with tagging red, yellow, green, and black. That is the order of priority for treatment. Red is where there's immediate threat to life, where they are such as an airway, shock, some bleeding that you can manage there. If the black is the opposite, where it may be treated as a priority in a normal setting, emergency room or trauma setting. In a setting where there's mass casualty, they try to save as many as they can, but they may have to give up some. So black is expectant or impending death. So they're not on the priority. The priority is the red. If you think of your stoplight, your red is priority, your second light is yellow, that's second priority, third is green, and that's in the order that it goes, and the black is the last. So immediate threat for red. Yellow is urgent, like if they have a fractured femur, something where they have a major injury that requires treatment, but their ABCD is okay. ABCDE. And Then your green is what is referred to as the walking wounded. They have some care, treatment, management that needs to be done, but it is not urgent. Hospital emergency preparedness, something you will learn wherever you're working. Every hospital has programs, has drills, has triages, depending on where you're working, and the hospital in the area can become the command center if there's a mass casualty in that area. CISM, CISD is critical incident stress management and debriefing, which needs to occur after any type of disaster, mass casualty, or anything like that. And that is the end of these chapters, and I will see you in class.